Good morning, ladies and gentlemen. On behalf of the organizing committee, we would like to welcome you to the 12th International Neonatology Conference on Hottest Topics in Neonatal Medicine, happening here at the spectacular Grand Hyatt Hotel in Abu Dhabi. My name is Lalaine Delumen, and it's my pleasure to be your host for today. This conference aims to bring together neonatologists, pediatricians, researchers, nurses, and healthcare professionals from around the world to debate and exchange the most recent breakthroughs, thoughts, and experiences in neonatal medicine. Our experienced panel of local and international experts with decades of expertise at premier institutes will showcase cutting-edge advances in neonatal care and research that are influencing the future of our specialty. We anticipate that this two-day meeting will be memorable and impactful. The conference is accredited by the European Accreditation Council for Continuing Medical Education for 14 European CME credits. We would also like to thank our sponsors and international hospitals, institutions for their exceptional support and major contribution to making this conference a reality. Our gold sponsors: Children's Hospital of Philadelphia, USA, Children's National USA, and our silver sponsor, KC. Our bronze sponsors, AstraZeneca, Wyeth Nutrition, and Nestle Nutrition. Our exhibitors, HESA Medical Equipments Co., LLC, Gulf Drug, Eon Diagnomics Genome Center, MedPro, Vigan, Al Jawahir Medical Supplies LLC, DuPharm, and Neotech. Without further ado, ladies and gentlemen, may we request everyone to please stand for the UAE National Anthem, followed by the few verses from the Holy Quran and video on the Emirate of Abu Dhabi.
بسم الله الرحمن الرحيم إنا فتحنا لك فتحا مبينا ليغفر لك الله ما تقدم من ذنبك وما تأخر ويتم نعمته عليك ويهديك صراطا مستقيما وينصرك الله نصرا عزيزا هو الذي أنزل السكينة في قلوب المؤمنين ليزدادوا إيمانا مع إيمانهم ولله جنود السماوات والأرض وكان الله عليما حكيما
In Abu Dhabi, our culture, spans generations. Our creativity runs deep. Through it, we reach out to each other. We reach out to the world. The foundation of our culture weaves us together, each one of us adding, connecting, inspiring, creating this spectrum of shared identity, a rich painting of where we are and where we are going. Together, we connect with our past. Together, we create our future. Together, we become who we are. We are our culture. And through it, we all belong.
To officially kick off this event, it is our pleasure to invite to the stage our two esteemed speakers to deliver us their welcoming address. First up is our Director, Medical Education, Adjunct Faculty, Khalifa University, and GMU Consultant Neonatology in Sheikh Shakbout Medical City, Mayo Clinic, Abu Dhabi, Dr. Junaid Khan, followed by Chief of Neonatology, Tawam Hospital, Al Ain, Professor of Pediatrics at UAE University and Khalifa University, Abu Dhabi, Dr. Ayman Rahmani. Please welcome our first speaker, Dr. Junaid Khan.
So, good morning, everybody, and assalamu alaikum. This is just we are a speaker, but later session. We just having this startup of our conference. So, what is the date today? What is the date? 12th of May. What happened at 12th of May? Nurses Day. Please give a big hand to our all nurses sitting there. Happy Nurses Day. You are, especially in the field of neonatal perinatal medicine, you are the backbone of our NICU. So congratulations on your nursing day. Having said that, it is 12th of May and it is 12th year of neonatology conference. As you can see, we missed only 1 year, which is 2022, due to some odd reason. And I must appreciate my colleague, my friend, and my co-chair is Dr. Ayman Rahmani, who with all those long years, he's tolerating me in, doing that. Not only that, I must appreciate our friends, our very esteemed professor, Dr. Eric from the CHOPS, and his team, always with us since many, many years. So thank you very much to come again. And Ruth, who is arranging all this for us. Thank you very much for that. So our conference is the same format. We have a mix of all the topics, but this year especially we have a neurology session. The last session is very important, and the last session today also is the neurology session. And I add up, last session tomorrow is the Q&A. So anybody has any answer, all the experts are going to be sitting here, and you are more than welcome to ask any question other than the regular panel discussions. So I will not say more than that, so please enjoy this conference, these 2 days, and I must say that very welcome in the Friday morning. This is 2 extensive days we have to. Just to remind you that we have 2 workshops, very successful, people will like it, and just who attend, please give us a feedback. With that, I just again welcome you and good morning, Dr. Ayman Rahmani.
Assalamu alaikum, good morning. It's really encouraging to have a full lecture hall in the morning on a Friday. Thank you all for coming and for sharing your time with us these 2 days. As Dr. Junaid mentioned, this is our 12th year, And we did something new this year, so we'd like to know your feedback about the actually 3 sessions you did yesterday about the workshops. So we did one workshop about non-invasive surfactant administration, and one about point of care ultrasound in neonatal lungs and neonatal brain. So please, for those who attend, please just give us a feedback, and we will try to expand this in the future, inshallah. As Dr. Junaid mentioned, we try to get all the sessions in according to the topics. So we start with very important topic today, which is innovation, and hopefully we'll also kind of get off to maybe next year's to more state-of-the-art topics like AI or something else that we have to do. Now, all the sessions are important. We'd like you to be interactive as much as possible. There's going to be a lot of microphone here for questions after the sessions. The sessions will be 4 lectures in each session, mostly, and followed by a question and answer session. So please, as much as possible, interact. We have esteemed speakers from Children's Hospital Philadelphia, from Washington, D.C. Children's Hospital. So we'd like you to, as much as possible, take this opportunity to gain from their knowledge and experience. With that, I will give the podium back to the MC to introduce the first speakers. Thank you.
Thank you so much, Dr. Khan and Dr. Ramani. Without any more delay, we believe everyone is excited to learn from our expert speakers. Let's begin with session 1 on innovation. Let me introduce our session chairs. Please welcome Dr. Sridhar Kalyasundaram, Consultant Neonatologist, Mediclinic Al Johara Hospital, Al Ain, and Dr. Faisal Sidgali, Consultant Neonatology, Chairman of Division of Neonatology, Sheikh Shakboon Medical City Mayo Clinic, Abu Dhabi. Session chairs, the stage is yours.
Dear colleagues, good morning everyone. And as Dr. Ayman said, it's amazing to see such a full house, and happy Nurses Day. I'd like to thank Dr. Ayman and Dr. Junaid for this kind invitation, and it's an honor to be chairman for the opening session. And innovation is the mother of science and medicine, of course, and the first topic is going to be on a very important aspect of neonatal resuscitation. So, human factor. I know the NRP has included more and more of team working, the human factor, into the neonatal resuscitation program. As the updates come every few years, this chapter is getting bigger, and there is more focus in our training sessions as well. The focus is on teamwork. The human factor does play a role, and it's my pleasure to introduce the first speaker who is going to cover this topic, Dr. Heidi Herrick. She's a attending physician, neonatologist at Children's Hospital Philadelphia in Pennsylvania. She trained in University of California, San Francisco, both for her medicine and the pediatric training. And subsequently, she went on to work in Philadelphia in the Children's Hospital to get her neonatal fellowship, and now she's attending there as well. Over to you, Dr. Heidi. Look forward to your talk.
Thank you for that introduction. As he stated, I'm Heidi Herrick. I'm a neonatologist and an assistant professor at the Children's Hospital Philadelphia and at the Hospital of the University of Pennsylvania. Today, I'll be discussing leveraging human factors to improve neonatal resuscitation. I have no disclosures. The objectives of my talk today are first, to define human factors, second, to understand the role of humans in complex systems, and third, to describe human factors application to neonatal resuscitation. Human factors is defined as a scientific discipline concerned with the understanding of interactions among humans and other elements of the system. It is also the profession that applies theory, principles, data, and other methods to design in order to optimize human well-being and overall system performance. It involves a study of all aspects of the way humans relate to the world around them with the aim of improving performance, safety, and/or costs. You may be most familiar with them in the field of aviation. In fact, here are some of the lessons that we've learned from aviation. Humans are a fundamental component of any system. They are uniquely able to function in uncertainty and to make trade-offs, and they can create safety in complex systems. On the other hand, complex systems are inherently unsafe. They always function on the limits of capacity and require safety to be traded for other aspects of system performance. Sidney Dekker summarizes this nicely in her quote, "Human error is the inevitable byproduct of the pursuit of success in an imperfect, unstable, and resource-constrained world." The importance of human factors and performance was made readily apparent to OB and to neonatology in 2004 when the Joint Commission issued a sentinel event alert stating that 70% of perinatal deaths and injuries could be attributed to communication breakdowns and deficient leadership. Here you see before you the System Engineering Initiative for Patient Safety model, or the SEIPS model. This is a human factors model that's used often in the healthcare setting. It's a combination of Donna Bedian's structure, process, outcome model and Carrion and Smith's work system model. As you can see, the model is divided into 3 distinct but interrelated parts: the work system, processes, and outcomes. I'm going to focus a little bit more on the work system as I think it explains human factors nicely. As you can see in this figure, the system is complex. Each component of the system does not function in isolation, but instead relies upon and interacts with every other element in the system. This figure also depicts one of the central tenets of human factors, that humans play a central and vital role in any complex system. Before I go on any further, I'd like to emphasize the importance of studying work as done rather than work as imagined. For human factors analysis, you must observe the work. That's why I've tried to leverage video recording and eye tracking technology whenever possible in my work. I've been lucky enough to work at 2 institutions that have video recording in the delivery room, but human factors analyses can also be done through direct observation. Now I'm going to move on to discuss how human factors can be applied to neonatal resuscitation, and I'm going to use the SEIPS model to discuss some of my completed, ongoing, and future work. We'll start with the work system. Eye tracking technology is a human factors tool that is emerging as a neonatal resuscitation tool. It allows us to assess human performance by assessing visual attention. It's been used in neonatal simulation as well as real-life resuscitations. My colleagues and I used eye tracking technology to assess the visual attention patterns of leaders during delivery room resuscitation. In a study of 18 resuscitations at the Hospital of the University of Pennsylvania, we described how leaders direct their visual attention. About half of their visual attention, 54%, is on the infant, and an additional 24% is on the vital monitor. In addition, we found an interesting thing where attending neonatologist exhibited a stereotyped gaze sequence pattern that we did not see among fellow trainees. In addition to just assessing the visual attention patterns, we performed another study, an ancillary study embedded in the monitor trial to assess the impact of respiratory function monitor introduction into the delivery room on provider visual attention patterns. As a reminder, the monitor trial was a multi-center randomized control trial assessing the impact of a RFM, or respiratory function monitor, on tidal volume achievement. Patients were randomized to either an RFM visible plus standard monitors or standard monitors alone, and the primary outcome was tidal volume proportion between 4 and 8 mLs per kilo. In the primary study, there was no difference in the 2 arms between tidal volume achievement. In this ancillary study, in a subset of the monitor trial, we assessed visual attention patterns with a visible versus masked RFM. In this study, we looked directly at the interaction between tools and technology, the RFM, and the persons, the provider in the delivery room. And this is what we found. With an RFM visible, providers equally distributed their visual attention between the infant, the vitals monitor, and the respiratory function. With a masked RFM, providers primarily looked at the infant 46% of the time, followed by the vitals monitor 35% of the time. So what does this tell us? It tells us with an RFM visible, providers spend about a third of their time looking at the RFM. While visual attention does not necessitate cognitive attention, it was a significant portion of their time looking at the RFM. Additionally, with an RFM visible, providers allocated less time to the infant, 29%, versus 46% with the RFM masked. The p-value is 0.05, so did not reach statistical significance, but we still think that this raises some interesting questions about the introduction of new technology into the delivery room. In the case that the provider was facile at RFM interpretation, decreased attention on the neonate may have actually helped outcomes, known inaccuracies of provider assessment of positive pressure ventilation with chest rise alone. On the other hand, if providers were not facile at RFM interpretation, this may have produced worse patient outcomes. Excuse me. Additionally, we think that this study shows the importance of studying the interaction between tools, technology, and the providers before the introduction of new technology into the delivery room. Clinically, I think this should be done anytime we're introducing new technology into the delivery room, especially with the ongoing push to introduce newer and fancier technology. I'm further looking at the interaction between technology and persons through my ongoing study, Attention of Leaders During Tracheolaryngoscopy, or the ALERT study. This study employs both eye-tracking technology and video recording. For this study, I developed a mobile video unit that we use in our intensive care nursery to video record tracheal intubations that are done in the unit. You can see here the photo on the right that shows the two views of the mobile video unit. It also records audio. In this ongoing study, there are two specific aims. The first is to characterize the leader's visual attention during neonatal tracheal intubation and to explore how this may vary by setting, delivery room versus NICU, and by device, video laryngoscope versus traditional laryngoscope. The second aim is to explore the association between differences in visual attention and key neonatal tracheal intubation outcomes, including the primary outcome of severe desaturation. In this study, we're directly looking at the interaction between tools and technology, the video laryngoscope or traditional laryngoscope, the persons, the provider, and the internal environment, the delivery room versus NICU. Now I'm going to move on from the work system onto the process construct of the SEEPS model. For my first study looking at delivery room processes, I leveraged video recording at the Hospital of the University of Pennsylvania. At the Hospital of the University of Pennsylvania, all very low birth weight infants and high-risk infants are resuscitated in a dedicated separate resuscitation room that directly adjoins the operating room. All VLBWs and high-risk infants are delivered in the operating room regardless of mode of delivery, and they're brought immediately to the resuscitation room. We video record all of these resuscitations, and here you can see an output from the video. We have a bird's eye view of the bed, a wide-angle view of the room, as well as streaming vitals monitor. We also have audio. All of these are synced using live capture software and stored on a secure server. These videos are automatically deleted after 28 days unless we get parental consent to keep it longer. Video recording prior to the study had primarily been used for audits for adherence to NRP or documentation accuracy. Not surprisingly, these studies have shown that errors and rates of deviations from NRP are high, ranging from 16 to 54%, with increasing rates of errors with increasing complexity of resuscitations. For this study, I wanted to move beyond just error identification, and I wanted to try to identify the predisposing factors that lead to these errors to try to improve the system-human interaction. It can be challenging to measure human factors impact quantitatively, but tools have been developed for this, and one of these tools is flow disruptions. Flow disruptions are defined as deviations from the progression of care that compromise safety and efficiency of a specific process, and they're derived from direct observation of clinical work. They demonstrate systemic failures to support human performance, and they can be used to identify, evaluate, and rectify the often hidden mismatches between system and people. Flow disruptions prior to the study had been studied in the cardiovascular operating room, the trauma bay, as well as the anesthesia world, and they'd been shown to correlate with surgical errors. Flow disruptions directly measure the process construct of the SEEPS model. The objective of this study was to identify and classify flow disruptions during the delivery room resuscitation and to look at their impact on key neonatal process and outcome measures. For this study, we included neonates less than 32 weeks gestational age who required respiratory support in the delivery room. In total, we included 32 resuscitations with a mean gestational age of 28 weeks and a birth weight just under 1 kilo. We classified flow disruptions according to an adaptation of Wegman's initial flow disruption tool, which is demonstrated here, and you can see the 7 categories. We found that flow disruptions occur incredibly frequently, 53 per resuscitation, which correlated to a median of 3.7 per minute. We found that extraneous interruptions were by far the most common flow disruption, followed by equipment and layout, and then followed by communication. We also found an interesting trend that types of flow disruptions vary by impact. On this figure, flow disruption impact is on the x-axis, and flow disruptions are clustered by impact, and percentage is on the y-axis. As you can see, extraneous interruptions were the highest low-impact flow disruption, demonstrated by the green arrow. Equipment, technology, and layout and coordination flow disruptions were the most common medium-impact flow disruption, demonstrated by the yellow arrows. And equipment, technology, and layout were the most frequent high-impact flow disruption, demonstrated by the red arrow. Additionally, we found that flow disruptions cluster at the beginning of a resuscitation, as the rate of flow disruptions was the highest in the first 3 minutes of the resuscitation, followed by the lower rates in the next 7 minutes. These variations in timing and impact have significant implications for potential targets for interventions to improve system human performance. In addition to just identifying and classifying flow disruptions, we wanted to see their impact on key neonatal resuscitation process and outcome measures, with the primary outcome of achievement of target oxygen saturation at 5 minutes. We found that flow disruptions were associated with an adjusted odds ratio of 0.92 with a 95% confidence interval of 0.8 to 1.04 of achieving target oxygen saturation at 5 minutes after adjusting for gestational age as well as training level of the team leader, with a p-value of 0.2. So what does this mean? This means that for every additional flow disruption before 5 minutes, there was an 8% decrease in the adjusted odds of achieving target oxygen saturation at 5 minutes. Clearly, with a p-value of 0.2, this does not meet statistical significance, but we believe this study was underpowered to show this, and we think that there's many opportunities for to continue to study flow disruptions. In fact, I think there's many different opportunities for this, but I'm actively pursuing 2 of them. First, I'm studying flow disruptions during neonatal tracheal intubation, both in the delivery room and the NICU. I'll be discussing some of this tomorrow in my intubation safety talk. And second, I'm studying flow disruptions among delivery room resuscitations of neonates with congenital anomalies, specifically congenital diaphragmatic hernias. In our study of congenital diaphragmatic hernia flow disruptions, we noticed some interesting trends in timing, or in variation in timing and order of key resuscitation steps during CDH deliveries, and we decided to take a deeper dive into this. So we're performing another study with these 2 specific aims. First, to describe the timing and order of CDH delivery room interventions, and 2, to identify system factors that impact delivery room resuscitation of neonates with congenital diaphragmatic hernia. We've included 31 CDH deliveries in this study, and here are some of our findings that we found. We found significant variation in timing and order of tasks. We saw a large task burden on the bedside nurse. We saw inefficient use of the respiratory therapist and airway providers, and we also saw significant room and bed spatial constraints. Let's first take a look at the variation in timing and order of events. I'll take a moment to orient you to this graph. Each line on the y-axis represents an individual patient's resuscitation, so you see 5 resuscitations here. Each of the data points represents a specific specific intervention during the resuscitation. And on the x-axis, you have time in minutes, up to 15 minutes. For orientation, the purple square represents intubation, the light blue triangle represents invasive T-piece ventilation, and the gray circle represents transition to the ventilator. In this simple analysis, you can see that there's significant variation in the timing and order of tasks, including lead placement, vital sign acquisition, and transition to the ventilator. Additionally, when we started looking at this more closely, we saw significant task burden along the bedside nurse. In this graph, again, each of the lines on the y-axis represents an individual patient, but in this one, each of the data points represents a specific task for the bedside nurse. Time, again, is on the x-axis. As you can see here, nurses are responsible for many critical, time-sensitive, and sometimes competing tasks, including taping an endotracheal tube, placing pulse ox and ECG leads, placing a sump, and securing the sump. In the current model, nurses are asked to do up to 12 tasks in the first 15 minutes of the resuscitation. In the same vein, we saw inefficient use of the respiratory therapists. After intubation, they were responsible for T-piece ventilation for extended periods of time until transition to the ventilator, which prevented them from helping the bedside nurse with taping the endotracheal tube or other tasks. We also saw inefficient use of the airway provider as they were holding the endotracheal tube and doing nothing else until it was secured. One potential solution for this would be to offload T-piece ventilation to the airway provider to allow the respiratory therapist to help the bedside nurse with completing all of those 12 tasks we discussed. Lastly, we saw significant variation in room setup, which was very significant given the spatial constraints. In these 2 photos here, the one on the left, you can see suboptimal setup, and on the right, you can see a preferred setup. In this figure here, the red circle shows the video laryngoscope. In the figure on the left, you can see that the video laryngoscope is not in the natural line of sight of the airway provider, necessitating them turning their head during the intubation away from the patient. In the one on the right, you can see that the video laryngoscope is in the natural line of sight of the airway provider during intubation. In this one here, the red arrow represents the oscillator. At the Children's Hospital of Philadelphia in our special delivery room, the standard of care is to use the oscillator for all severe CDH patients or liver up as the primary mode of ventilation in the delivery room. In the photo on the left, you can see that the oscillator is behind the video laryngoscope and the RFM, making it difficult to transition the patient to the ventilator. In the one on the right, the ventilator is right next to the bed, allowing efficient transition to the ventilator. We're actively working with our nurses and our respiratory therapist to design the preferred setup, and we've been looking at our videos and noticing that we've actually been having the preferred setup in the majority of the videos moving forward. I've talked a lot about the work I've done in the work system and processes, but I've done less work in the outcomes construct of the SEEPS model. Through my work, I've noticed that there are significant gaps in the literature about delivery room outcomes and their definitions, and I've realized that I need to start to address some of this in order to be able to evaluate the impact of interventions in the delivery room. 2 of these specific gaps are first, defining and standardizing delivery room outcomes. The ILCOR Neonatal Task Force took a large step towards this in their recent publication entitled Recommended Guideline for Uniform Reporting of Neonatal Resuscitation, the Neonatal Utstein Style. The second gap is we do not currently have quality of care metrics for the delivery room, and I'm actively working to try to rectify this. I'm doing this through two specific avenues. The first is I was awarded a career development grant from the Agency of Healthcare Research and Quality entitled Leveraging Human Factors to Evaluate Quality of Neonatal Delivery Room Care. The objective of this study is to develop a comprehensive human factors quality approach. And here you can see the conceptual model of the grant. The first aim is to perform an in-depth delivery room work systems analysis. The second aim is to identify and refine delivery room quality metrics using modified Delphi process. And the third aim is to assess the inter-rater reliability and validity of these quality metrics through a multi-center video review. The second avenue that I'm pursuing for this is I'm developing a multi-center international video collaborative entitled Video Evaluation of Resuscitation of Infants International, or VERIFY. The objectives of this collaborative are to develop and measure consensus quality metrics of delivery room resuscitation, and two, to develop a platform that can be used for future interventional and observational studies and quality improvement initiatives. We're starting with 7 centers across 4 countries that combined represent greater than 20,000 deliveries per year, and our goal in the future is to expand to further sites. Through my work as a human factors researcher over the last few years, I've learned a few lessons. First, observations are worth a million words. Whether it be in person or video recording, observations allow incredible insight into work as done versus work as imagined. Unfortunately, I've also realized that video analysis takes time. I'm actively working with collaborators to automate some of this process, but in the meantime, I need to thank all of my collaborators for their help with their video analysis. I've also realized that resuscitation, whether it be in the delivery room, in the NICU, or during tracheal intubation, takes place within a complex system that requires the coordination of persons, equipment, space, and patients. And lastly, studying just how one component of a system works won't give you insight into the entire complex system, and rather, a human factors analysis is necessary to understand complex systems. And with that, I'd like to thank you for the opportunity to talk with you.
Our next speaker is Dr. Ayman bin Ayad. He's a consultant neonatologist at Toam Hospital, which is a level 3 tertiary unit. Ayad, he completed his neonatal fellowship at University of South Florida and Johns Hopkins. He served also as a transplant medical director and also as an NRP instructor. Ayad's talk today is about pre-transport stabilization and stable approach. Please welcome Dr. Ayad.
Thank you very much. Good morning, everyone. Today, the topic about pre-transport stabilization and the stable approach. I have nothing to disclose. So the objective for today, I'm going to give an introduction about the transport and pre-transport stabilization, different type of the transport or neonatal transport teams, pre-transport stabilization, and then stable approach, and awareness of the challenges during the transport. As we know, there's a significant number of the neonates required emergent transfer to the tertiary care center, often because of the medical, surgical, or rapid emerging postpartum problems. Identification and rapid stabilization of the sick infant decrease the morbidities, mortality rate, and morbidity rates in the transport setting. Because the outcome of the outborn neonate with the major medical or surgical problems include extreme preterm babies remain worse than for the inborn hospital or inborn infant, primary emphasis should always remain on the prenatal diagnosis and subsequent in utero transfer whenever is possible. Despite advanced training and technology, mother will usually make the best transport incubators. As everybody knows, there's two types of the transport team available. Dedicated transport team, which is the dedicated team in hospital, freestanding affiliation. And another one is the unit-based team, which is staff unit or inside the neonatal care unit. And that's mainly in UAE, versus in the United States, it's been well known. It's been practiced for 30 to 40 years as a dedicated transport team. This is my picture when I was a transport director at the Mercy Hill Jovan Bay Hospital. I was enjoying working there in 5 years. So the goal of the pre-transport, stabilize the infant, anticipate that transport can be stressful and challenging. According to 2015 American Academy of the Pediatric and Neonatal guidelines for the air-ground transport of the neonatal pediatric patients, the main goal of the neonatal pediatric transport team are early stabilization, initiation of the advanced care at the referral institution, with continuation of the critical care therapist, and monitor en route to improve safety of the transport and the patient outcome. It's very important to know your equipment. Know the ambulance, your helicopter. Working knowledge will allow the best use of the space management and ensure rapid access to supply and equipment when needed in emergency. As everybody knows, sometimes during the emergency, the transport space is very small. So you have to know your equipment, your area very well. Regular simulation training in the transport vehicle to enhance or to ensure the team will function effectively during the stressful transport. Secure medical equipment, supply bags for both safety and function, and review the location of the necessary and emergency equipment and supply prior to transport. Here a case of 23-weeker that we are commonly face, 500-gram neonates with respiratory distress granting shortly after birth. Baby was intubated at the referral hospital on conventional vents. Transport through the ground. On arrival, temperature was 35, heart rate 150 beats per minute, respiratory was 80, saturation 85, capillary filling time 3 seconds, sugars 55. Chest X-ray reported UVC at the T12. So what's the problem here? So baby arrived hypothermic, temperature 35. So we identified there's issue with receiving the baby cold. Baby tachypnic, despite being on ventilation. DSAT, and the UVC at the T12. So now we evaluate there is certain problems need to be fixed. Hypothermia, respiratory distress, we don't know. Is it because of the baby already collapsed lung, or there is some mechanical like pneumothorax, some surgical need to be intervention? Baby hypoxemic, either because of previous reasons or other reasons. And the line is the low line UVC. So now, what we think the underlying cause? Is it because of the baby happened before the transport? They were not well recognized those issues, or during the transport? So that's why stable approach come in place. So pre-transport stabilization is the period of stabilization at the referral unit was associated with significant improvement in the infant condition. In fact, also during the transport, the time spent to stabilize the sick infant before reaching your destination is crucial in improving the outcome. Pre-transport stabilization. Stabilize the patient as much as possible at the referral center prior to transfer to ensure you have successful or secured airway, adequate IV access. We prefer at least 2 IV access. Medication and fluid that will need during the transport are best drawn up and labeled prior to leaving the referral hospital region or center. Contiguous plan, and that's the crucial step, should be in place. Everybody knows there's a lot of challenges, either during the ground transport or the air transport. Thermal changes, worsening respiratory distress can happen during the transfer. Baby might get to the shock, dehydration, either second or third spacing or DIC, hypoglycemia, and might get worsening septic condition, septic shock. So it's very important to stabilization baby before transfer, and you constantly keep an eye on the baby during the transfer. So what's the stable approach? Is the mnemonic use in the stressful situation, and that can improve learning, organizing, thought. So the S stands for the sugar and safe care, T temperature, A airway, blood pressure, lab works, and emotional support. It's designed by the Christine, it's an American nurse practitioner with experience in the neonatal transport, ECMO. Stable program took place in 1980, and early 90, a lot of modification happened, and program underwent major revision, research and testing with evolution to the present from today. It gives the staff mnemonic-based approach to the neonatal stabilization. So as I said, this concept of the thermoregulation and prevent cold stress, maintain the normal acid-base balance, support ventilation, establish IV access, monitoring and normalize blood sugar, support blood pressure, normalize the heart rate, performing and interrupting lab investigation, obtaining review records and X-ray, educate and maintain involvement the family. So the S stands for the safe care. So when you receive a call, always think, is it the safest approach to transfer the baby, or better to bring the mom and then deliver the baby? If it's not possible, then anticipate, recognize, and manage. Sugar. Knowing the risk factor of your baby, knowing that some babies that are higher risk for hypoglycemia than others, like preterm babies, LGA, small for gestational age, baby IUGR, IDM, as we know. Some sick babies, they are more risk for hypoglycemia than the others, and that's also affect the outcomes. Some maternal use during pregnancy, like beta blocker, can cause hypoglycemia. So general guidelines, if sick baby, keep baby MBO, have the IV access, start fluid, and usually we prefer central access. If there's no, then at least 2 peripheral line in case of emergency. T for temperature. Those infant high risk of hypothermia, as we said previous, preterm low birth weight or IGR, infant require prolonged resuscitation, those sick babies. So as we know, there's certain type of the mechanical heat loss, evaporation, conduction, convection, and radiation. So prior to transfer, pre-warm to the 36.5 using the transporter incubator. Ensure baby euthermic at the referral hospital. Wrap the baby, use the hat cap. And sometimes you need to wrap the baby with the embrace or the incubator, inside the incubator. So the air for the airway. Assist the airway for any secretions. Ensure the neutral position of the neck. Assess the respiratory distress. Keep constantly monitor the saturation. Assess your baby whether required non-invasive or ventilation. Always keep in mind to leave LAMA or laryngeal mask available as size 1, which is suitable usually for babies more than 2 kilo or more than 34 grams, although now they're available of the smaller 1.5 for those useful for maybe for those microbramies, sorry. Blood pressure, constantly measured for those baby at risk for shock. Check the heart rate, capillary filling time, blood pressure. Assess need for IV bolus, and consider have the dopamine available at any time you need to use it. L for labs. Check again blood gas. Assess for infection, CBC, CRB, blood culture. Electrolytes prior to transfer your baby. And review the image. Make sure you document it very well. Where's the line? So at least when you receive the baby, you know before you transfer the baby, the line was the right position. That means most likely happened during transport. So keep an eye on the lines. Here's an important step, which is E, the emotion. Most of us, we forgot to discuss with the parents prior to transfer. Emotions parents may experience when their infant is sick or premature, including guilty, anger, disbelief, fear, depression, etc. Whenever it's possible, provide support, assistance to help the family cope with this crisis and their grief. Educating and maintaining involvement with the family. Strengthening professional can improve the condition of the high-risk neonates and increase safety of their transport. So always anticipate the plan, knowing your environment, use all available information that you have. History is very important. Mobilize the resource around you. Try to communicate effectively with your team prior to transfer. Call for help. It's very important. If you're stuck, just call for help. Establish the rule from the beginning. Knowing who's your leader or the leader during the transport. And use the cognitive aid, the NRMB card if you have it. During the emergency, sometimes it's good if you have the card, so it guides you what you need to do. How to keep all these? By practice, debriefing, and quality monitor. So our case, evaluation, baby sugar, when we did this table, sugar, 55, temperature was low, T, so you documented the baby has low temperature. Airway assist, there is no secretion, but the baby was tachypnic. Blood pressure, assist, circulation. Line, we discovered already that baby has a low line UVC, and you already discussed with the parents prior to transfer. So we identified the issues, hypothermia, tachypnic, and malposition of the IV axis. Now it's easy to address each one before the transfer. After you stabilize the baby at the referral center or before the transfer, then the next step is that during the transport, keep constantly maintain the temperature during the transport. Keep an eye on the airway, monitor saturation, FiO2, circulation, color, capillary filling times, blood pressure, and communicate with the team and inform your consultant or your attending prior to transfer the baby. Go over with the plan. Sometimes they have a better vision. They can guide you if they need troubleshooting. And then if it's happened any issues during the transport, as always, keep communicating with your team and with your primary consultant on call. Team concentration. Be aware that the team member who have motion sickness or catastrophe during the, or claustrophobia during the transport. Some people, they have the issue during the flight. And it happened to me a long time ago. I have one of the transport nurse. She has some catastrophic effect during the helicopter and always about to fall. So every time she wants to go, she will have kind of phobia from the transport. So it's better to know your team before you consider who's going to go. And have the open communication with them. Ensure the good communication among all team members, including the pilot and the driver. Be prepared to the changing environment and, if necessary, for the well-being of the patient. It may include pulling the ambulance over, landing the helicopter, or fixed-wing aircraft. Sometimes there's noise in both air and ground transport. Can be troublesome, challenging, and stressful. Even moderate background noise may force transport team member to develop compensatory strategy to assist the patient, like visual assessment of the chest expansion, change respiratory effort, level of consciousness, or discomfort to detect the change in the patient condition. Try to keep an eye on the vital sign instead of try to listen by using stethoscope on the heart rate or respiratory rate. Knowing that some challenging also happens during the transport. Previous studies have suggested a high level of unpleasant incident during the inter-hospital transport, and most of them are related to the equipment failure. or failure to recognize poor oxygenation or shock, and shock. Such an incident can be reduced by appropriate training of the staff, forward planning, familiar with retrieval equipment. So in summary, stable approach can be used by the transport team to ensure everything in the right spot. You already assess the situational. That means before you accept the baby, make sure is it the good to transfer the baby or better to transfer the mom. Make sure you have the list of the stable sugar, temperature before you transfer the baby, airway secured, blood pressure line in place, and lab assist. And then you discuss with the parents and be open, very clear about the sequences of the transport, risk and benefit. Don't forget there's always ABC prior to approach the stable, which is the secured airway, breathing, circulation, drugs, and demonstrate plan. Thank you.
Our next speaker is Dr. Natalie Rentall. She's a professor of clinical pediatric at University Hospital of Philadelphia. And Natalie, she's also co-director of Special Delivery Unit and also director of Neonatal Surgical Services and the director of Neonatal ECMO program. She's also interesting. She's a fetal consultant and consultant with the perinatal palliative care program. And she's the main lead investigator for the Delivery Room of the Future Frontier program. And her research interest is neonatal surgical and cardiac, including CDH, myelomeningocele, preoperative care of surgical neonate, and ECMO. So she will give us a talk today, as I said, about the Delivery Room of the Future, which will be a very interesting topic. Welcome, Dr. Natalie.
Good morning. So isn't it absolutely amazing that at the time of delivery, a baby can emerge from a liquid environment and come out and breathe air? And most times this happens seamlessly, and these babies don't need any help with their transition. But what about the baby with a congenital anomaly? A baby with a very unique physiology and anatomy. They need help. The help they receive in the delivery room is often very variable. Variable at centers all around the world, and also variable within centers. So I want to start by thanking Dr. Ayman and Dr. Junaid for the kind invitation to come here today and speak with you and share a little bit about our program. Thank you. So my name is Natalie Rentall. I'm a neonatologist at the Children's Hospital of Philadelphia. I'm originally from Canada, but I went to Philadelphia in the 90s, and I started to work with the fetal team. I've been there ever since, and I work on neonatal and surgical clinical programs, and it's really been an incredible experience and collaboration. What I'm going to share with you today is a little bit of the work that we have done and that we plan to do as part of the Delivery Room of the Future program. This program is an internal accelerator program, really to support visionary research and as that translates into cutting-edge clinical care. The goals of this program are to establish anomaly-specific optimal care guidelines, to apply a human factors framework to optimize team performance, and to develop an interactive digital coach to support decision-making in real time. At this point, I have no disclosures. So today, I want to stress the importance of recognizing the need for resuscitation guidelines for infants with congenital anomalies. And then I'll go over the 3 aims of the Frontier program in order to discuss the physiologic data capture in a registry that will inform modified neonatal resuscitation guidelines for infants. Then I'll also discuss methods to improve teamwork and communication during rare scenarios by applying human factor science, and discuss a novel cognitive aid for the resuscitation of infants with congenital anomalies. So I'll start first with this need for specific resuscitation guidelines for babies with anomalies. There's about a prevalence of 3% of the live births in the US, 2.4% in Europe, and I found this number from the anomalies register here in the UAE that said 7.89 per 1,000 live births. The most common anomalies are spina bifida, transposition of the great arteries, CDH, and omphalocele. Birth defects are merciless, no parent is immune, they are mysterious, and one of the leading causes of infant mortality. What we know is that 10% of all newborns require resuscitation at birth, and 100% of high-risk newborns require resuscitation at birth. And I think that we will all agree that the delivery room management can affect the outcomes of newborns. We have this program that we do through the Neonatal Resuscitation Group and the American Academy of Pediatrics, and we're certified in that. And we also train in pediatrics, and then we do neonatal, perinatal fellowships. This really prepares us for all newborns in general. Newborns where their transitional physiology is defined, where there's evidence-based delivery room resuscitation recommendations, and where there's a low risk of mortality and morbidity. But what about the newborn with a congenital anomaly, where the transitional physiology is unknown, where there's no evidence base for this, and it's really based on expert care, and there's a high risk of mortality and morbidity? Many publications on delivery room management are really just provide grade D evidence, and the publications are sparse, and we know that they are not related to evidence-based practice. And this golden hour is, so important. And what I've realized over time is that we really learn by apprenticeship. We with our senior colleagues, and that's how we learn to care for these high-risk situations in the hospital. Because the guidelines in the textbook of NRP doesn't cover a lot of detail on the anomalies. In fact, the special considerations chapter has very little on non-cardiac anomalies and doesn't even mention cardiac anomalies. So it's quite disease agnostic. And we know that complex babies have complex resuscitations. So what we're trying to do is put our individual experience together into expert consensus to try to create some evidence-based care. Then we're going to mix it in with human behaviors and team performance and synthesize it into an interactive digital coach. This is really the mainstay of our work in the program. Really, the way that we've been able to do this is because I work at a center that has a really high volume through the CFDT. We opened the first birthing center, the special delivery unit, in 2008. So we see over 500 deliveries a year of babies with congenital anomalies. So with this high volume, we've seen over 5,000 deliveries. We're putting that information together, and we figured we have enough volume and numbers to create standards in this area. I have an incredible team. I think you've heard Ann Ades at this conference before. She's our specialist in education. Liz Foglia is our resuscitation scientist. I'm sort of the one that's been around the longest with some of the crazy ideas that my team goes with. And Tom, he's a real innovator. He has a background in business, and he's been an incredible addition, really forcing us as clinicians to look at what we do in a totally different way. So it's been a nice combination of work. So next, I'm going to discuss some of the physiologic data capture that we're putting in a registry. And I mentioned Tom a few minutes ago. He really has been the mastermind behind the Clinical Outcomes Data Archive, which we call CODA. The goal of this is to track resuscitation variables for all diagnoses, and then to see in real time the risk-adjusted clinical outcomes. And this is just a screenshot from one of the areas where we can look. And we've really been able to incorporate the mother and the baby information, and that's quite a complicated dyad in the healthcare EMR for some reason. But we've been able to put that together, which is quite helpful. And then you can see here, if you click on CDH at the top, all of this data comes up. And the data is continually abstracted and validated. So at any moment, if we're seeing a mom, we can pull up all of our current numbers and all of our current data. And then we can also go back and look at medical procedures and then divide it up by diagnosis. So it really has been a powerful tool to tell about our experiences, because each experience tells a story. So not only are we accumulating the mother and the fetal and the newborn data, but we also follow these babies through their ICU stay, through their outpatient time, and as they get older. And really putting all of this together helps us to inform how we should change what happens in the delivery room. So in terms of transitional physiology, it's very important to look at lung aeration, how the circulatory system transitions, and the transitional oxygenation. The circulatory transition is fascinating, and the impact of delayed cord clamping is really phenomenal. But this is too much for today. That's a whole other talk. So I'm really going to focus on lung aeration and some of our work with transitional oxygenation. Dr. Taylor Wild has really led a lot of the work on transitional pulmonary physiology in the CDH babies. She did this work with the RFM monitor that Dr. Heidi mentioned earlier. And that monitor is inserted in line with a connection from the endotracheal tube to either a flow inflating bag or a T-piece. We put that on immediately following intubation to provide tidal volumes and carbon dioxide levels. We keep it in for about 30 minutes or until transition to a ventilator, whichever occurs first. So here's the data on the first 50 CDH patients that she looked at. And really what we can see is, from the time of intubation to about 10 minutes of life, the tidal volumes increase. But there's a lot of heterogeneity and a lot of differences even within, between patients. And so what we're doing now is using this information to really individualize the ventilation approach for babies with CDH after delivery. And this curve will be familiar to you, the reference range oxygenation saturation curve after birth. I think this is fascinating who put this together. So Jennifer Dawson was a PhD student in Australia, and she looked at 468 normal newborns and followed their saturation. And she looked at the 3rd percentile to the 97th percentile and came up with these curves. The NRP took the 50th percentile and then created our target saturation goals that we all use now. At a minute, 60%, much like a fetus, and then by 5 minutes, we expect them to be 80%. But this was the origin of this work, based on 468 patients. So what we're doing now is looking at all patients with different diagnoses, because we don't feel like it's fair to extrapolate from the normal newborns to infants who have anomalies and to expect them to achieve the same saturation. So we did a project with over 200 infants with cyanotic congenital heart disease, and we looked at 3 different phenotypes. This is the data for the babies with transposition of the great arteries. And this is the Dawson-like curve that we created for those infants. So that's our plan with this program, is to create curves and standard data for all diagnoses. In addition, we're also working on special recommendations for special handling and positioning of all diagnoses. So in an effort to create evidence-based resuscitation guidelines by putting together this transitional physiology, integrating it with clinical outcomes and identifying critical targets, and then hopefully after we put this together, we'll be able to study therapeutic interventions and conduct large trials more efficiently. Next, I'll discuss methods to improve teamwork and communication during rare scenarios. Because we know that in more than half of delivery room resuscitations, we deviate from our local guidelines. Errors are more frequent in complex resuscitations, and team performance is really important, and it really hasn't been assessed formally, although Dr. Heidi's doing a lot of work, but it overall hasn't been assessed on large scale. So to optimize team performance, our group's looking at video review, a lot of human factors work, mapping our behaviors, simulation, and innovation. And so now I just wanted you to picture, so you're at work and you're being called to a delivery, a transposition of the great arteries with an intact atrial septum. So whether you're the physician, the nurse, or the respiratory therapist, whether it's the first time you've ever been to one of these deliveries or you've been to many of them, or maybe you've just graduated or you've been around 30 years, each one of us running to that delivery will think we're thinking about the delivery the same way and have a shared mental model, but we often picture it quite differently. And I like to think of it sort of like this. What if I asked you to picture an apple, right? Some of you might picture this, or really any number of different versions, right? We all think we're thinking of the apple, but we're thinking of it quite differently. And then now if I ask you to recall what the apple looked like, you might even have a different picture again. And this really, to me, forms the foundation for why video review is so important. Because what it allows us to do is to look back and not rely on memory of a debrief, but actually look back and say, what happened? And then we can systematically map the resuscitations for rapid cycle improvements so that moving forward, we can all share the same mental model. And Dr. Heidi mentioned this too, the video review of the CDH delivery. We've done many of those. And in fact, it was really informative to help us, determine optimal position of equipment and other behaviors. In fact, we use that information to create guidelines. And so this is sort of what it looks like, essentially. We've got these large screens, these digital screens up in our resuscitation rooms. And based on our debriefings and video review, our individual experience, our expert consensus, we've put together guidelines that helps us all get onto the same mental model as we move forward in deliveries. And, we know that with process mapping, there's a lot of variability in critical task timing and sequence. And that was mentioned in the earlier talk as well. And we know that this timing and sequence is actually really, really important. And we know that from other high performance teams, like it's very, common to hear about the pit crews and such. And so, I wanted you to picture the craziness in the hospital, and this happens to us all the time, right? You're getting called to a CDH delivery, liver up, severe prognostic categories, And then an hour later, they're calling for, you know, a hypoplastic left heart syndrome, and you have a different team going to that. And then simultaneously, and this does happen some days, right? Simultaneously, there's going to be a C-section for a mom carrying a baby with spina bifida. So you've got different teams, a different team composition every single time, right? And you're all running and trying to do the best. Each situation is very unique. A lot of times there's no team familiarity and chemistry, and these different team dynamics, knowledge, and experience make everything that we do so risky. And then, of course, what happens, you know, in the scenario where unexpected things happen and you're working with a different team, how you handle that is really, really very variable. And so these are important things to work through ahead of time with your team and to come up with algorithms and plans. We do a lot of work with simulation as well in our simulation center, and this really does support preparation for our resuscitations and helps us to pilot new equipment. We're also doing a lot of work with innovation, and Dr. Heidi mentioned the eye tracking work as well. Now I'm going to discuss the novel cognitive aid for the resuscitation of infants with congenital anomalies. And, you know, one of the things I think is so interesting, you know, when I was coming over here, you know, I was so worried about, you know, the flight. Am I going to have an aisle seat, a window seat? You know, or am I going to get something to eat? Will it be quiet so I can work on my slides? You know, there's so many questions. But the one question that I didn't know the answer to was, who was my pilot, right? And so what we do is we just hope that they've got checklists and they know what they're doing, but we actually don't know them, and they're in charge of the whole situation. And further, like, are they a good person? Do they know what they're doing? How well do they work with their team and their co-pilot? And I think it's very similar. If you look at the cockpit, I realize it's so similar to what our resuscitation room looks like. And it's also very similar to, like, a mom comes in to deliver. Many times we haven't met them before, and they're assuming that we are going to follow the plan, follow a checklist, and keep things very safe and organized. But we all know how variable what we do, you know, what we do. So cognitive aids can prevent errors, but most are static and they don't address behaviors. And they're really important because clinicians, we have to synthesize complex information during a rapidly evolving resuscitation. So this really is our goal with this digital coach that we're creating right now. We've had prototypes that were kind of clunky and not as interactive and didn't move with us as fast. So really what we're working on now is like another version so that it's very dynamic, not passive. It's going to target team performance and patient physiology, and it's going to integrate with our clinical monitors in real time. So this is currently what we're working on, so we'll have more information on this for you in the future. And I saw this video last week, and I just loved it. I mean, this is unbelievable, but it really spoke to me about what we all do, right? Everything that we do requires incredible skill and precision, and they're tiny humans, right? Every millimeter, every milliliter counts and makes a big difference. So by leveraging technology in the SDU, by looking at their NIRS, their brain monitoring, incorporating other physiologic monitors, the Moberg, video recording, doing rapid cycle feedbacks, you know, this is all part of our novel delivery room learning system. And it's really what we're using such that every resuscitation will inform our next. All of our previous work informs our next. So this is our learning health system. And in this way, we can standardize what we do, but we can also know how to individualize for unique aspects. And hopefully we will improve outcomes of these babies with this approach. So if we look back on NRP recommendations through the years, what we're really hoping is that in 2023, 2024, moving forward, we're going to be able to stream real-time physiologic data superimposed on diagnosis-specific reference ranges and, use this critical knowledge digital coach. So this is our view of the delivery room of the future, and I mentioned earlier that I'm, from Canada, and I, know that all snowflakes are totally different, and I can say that because I'm Canadian. They are all different, and that is very true for newborn resuscitations. Every single one of them is a little bit different. So our goal is to, come up with this program and standardize what we do, and then, work through it in our hospital, but then to share it to other centers and, really create the standards. So that's part of what we're working on with our program, and it's been a pleasure speaking with you this morning and sharing our work. Thank you so much.
Thank you so much, Dr. Natalie. It was a fascinating presentation, and you're lucky to work in a center which faces so many of these rare anomalies. So the evidence that comes from these will help all of us who deal with that less frequently. And now the final talk of this session. It has been a fascinating session, and I'm sure all of you will have questions. So after the talk, we will have 10 minutes for all the speakers to interact. Please note down your questions, and we will have the question session after this. It's my pleasure to introduce my dear colleague and friend, Dr. Faisal Ziddali. He is consultant neonatologist. He is chair of the Division of Neonatology at Sheikh Shakbout Medical City Mayo Clinic Center. He has been in UAE for almost 10 years now. He trained in Glasgow and trained in neonatology and pediatrics in UK. He worked as a consultant in Manchester before moving to Cornish Hospital, and now he's in SSMC. He's actively involved in many projects with the Department of Health, including the Department of Health SEHA collaboration previously, and now I was lucky to be with him in the Tasnif peer review audit for all the neonatal units along with Professor Nina Modi. So he will be speaking on a very interesting topic which doesn't have any easy answer. It's about limits of viability and what we do, both the ethics and the practical suggestions. Over to you, Dr. Faisal.
I was told earlier in the meeting, actually, that I'm very brave to stand up here and talk about ethics, especially when you're talking about, limit of viability. I think what I ought to do, actually, trying to deviate as much to the ethic than looking at the data. And what I noticed, actually, if you, as I said, when I started my training in the early 1990s, neonatology, we used to really struggle with 30-weekers. We really had difficulty 30-weekers. Are they going to survive? Are they going to be? They had severe RDS. There was not a significant antenatal steroid. But things has moved on. And in the past, I remember when I said we had 22-weeker, and I said, oh, is the baby dead? Now, I say, how is the baby? Especially after the first 12 hours. If the baby survives after 12 hours, there's a higher risk, chance of survival. I'm trying to actually with this show you the data because somehow we are very aggressive from obstetrician and neonatologists when it comes to 23-weeker. But when it comes to 22-week, completely different. And I'll show you some of the data to say that actually there's not much difference between the two. But we have a completely different approach. So that's what I'm trying to do. I'm not really advocating that we should be resuscitating all 22-weekers or 23, but I'm showing to show you the data that actually there is a case to make. So I don't have anything to disclose. So the first thing is actually, I'm just going to give you a scenario, a couple of slides, and then I'm going to go back to the end of the outcome of the scenario. So 30-year-old lady, pregnant, twins, IVF, she's been trying for 10 years, presented to labor at 22 plus 2 days. and she had having bleeding, rupture membrane for 23 hours, and complication with chorioamnionitis. So we did have, actually, we were lucky enough that we had the chance to speak to the mother and the father before the delivery. Sometimes you don't have that luxury. The lady comes and delivers. So really, after having the consultation with the family regarding resuscitation, what is going to happen when the baby is born, what the predicted outcome, and that predicted outcome most of the time is actually international data than our own data. So we had to tell the parents what actually these outcome for a baby at 22 weeks. So the discussion, the parents, we did have to kind of go ahead and tell them that there is also the approach of being really very kind of proactive management of obstetric, use of antenatal steroid, and active neonatal intervention. Despite telling the parents that long-term, the survival is very low in 22 weeks, talking about complication of extreme prematurity 22 weeks, they really still wanted to go ahead with full resuscitation and everything that we can do. So that was, and we had to really kind of take that in consideration, the parents' wishes. So there are twins, as I said, so the first girl for 504, and the other one, a boy, which was a little bit smaller, 475. They were actively resuscitated as the parents' wishes. They were intubated, and they were admitted to an ICU. This is just really the reason this is pictures of the twins. You can see the eyes and ears because this is 2 weeks of age. In the beginning, the parents did not want anything to happen because they didn't think the baby was going to survive. So really, looking at prematurity is the majority of neonatal death due to prematurity, and significant part of it, or part of infant mortality. But as in the tendency, as I said recently, in the last 10 years, there is more of these babies are born, and they are surviving, and with the proactive care. So what I'll do, I will show some of the data from UK and some data from US, and then after that, I will show some local data regarding extreme prematurity, concentrating specifically really at 22 weeks, comparing it to 23. So this one actually looking at the outcome, babies born at 22 weeks. So the first column, you can see 22 and 23, and this is from the Epicure study. This was done in England. The first Epicure one was 1995, and then 10 years later, we had Epicure 2. So if you look at babies who actually died, the majority of babies 1995 really did not survive, and then they had, as I said, severe disability. If you look at 2006, 10 years later, there was some improvement, but not a lot. And if you compare it to 23-weeker, you can see actually there is not much difference between the two. And then we're looking here at survival if had active treatment given. This is again from published in 2019, but this is actually the first one, the Embrace, is the UK one. And it's very clear again, if you look at survival for active resuscitation, 1 in 3 probably if you put them together at 22 weeks, and at 23 weeks, around 1 in 4. So it's not much difference. So that's what I'm saying. And if you look at the Swedish, yes, it's more, especially at 23 weeks, and then the NICDH from 2006 to 2011 had a kind of similar, and the systemic review. So there's not much difference really in survival between 22 and 23 weeks. And if you look now, because the two things we're looking at is survival and the neurodisability. It's the two aspects that I'm comparing these two type of extreme gestation. Again, if you look at overall, there's really not much difference between the 22 to 23, slightly, but not a lot really. Now, this is actually interesting. This is from the BAPAM data 2019, and this specifically comes from the Embrace. The Embrace basically is a collaborative data collection for all babies born in UK, looking at the maternal and also neonatal data. So if you look at the first one at 22 weeks, again, it depends how you want to look at it. Do you want to look at how many babies survive or how many babies died? So at 22 weeks, if you look very clearly, around 7 out of 10 babies really died. But there's also a wide range between 51 to 79%. The reason for that, because they are not sure about the data. And that's the problem with this data. There's a lot of areas where babies who are not declared as a live birth, and this makes it very difficult. And then if you look at the neurodisability, severe disability is 1 in 3. So there is significant neurodisability, and really the range between 24 to 43. And even the ones who do not have severe disability, a quarter of them will have moderate neurodisability with moderate CP, mild CP, learning difficulty, and behavior problem. And this can be really significant later on for the families. If you compare that to the 23-weeker, again, really not different, 6 out of 10 die, and the other ones, and 22-weeker is 7 out of 10. Neurodisability, 1 in 4. So comparing the two, there is really not much difference between the two. This is just to highlight it again, and it's in a big way. Now, US data is interesting, really. This is published in 2022 by Edward Bell. It's a part of 19 US academic medical center between 2013 2018. They were comparing it to the previous cohort between 2008 to 2012. And they had around almost 11,000 infants born between 22 to 28 weeks. And they managed to follow up because they're looking at two things, looking at survival and they're looking at neurodisabilities. So they managed to follow 2,566 babies below 26 weeks up to 22 to 26 corrected gestation. The interesting survival to discharge for a 22-weeker, around 10% for live born. But if they were actively treated, I will define later what active treatment means, you're now increasing it 3 times. And that is only active treatment. Most of it they're talking about postnatal than during the antenatally. So that's really the difference. So when we say earlier that 3 out of 10 babies, survive, that is because the babies were actively resuscitated. But if you don't do anything, it is actually significantly drops. Okay, so in this study, which is really a large study, I'm going to just talk about characteristic of the two groups of the 22-weeker and 23-weeker, looking at the maternal, infant, the antenatal care they receive. If you look at it, there's a preference for 23-weekers to be treated differently antenatally. So a mother comes at 22 weeks, it seems to be different. If you look at the antenatal steroid, there's a big difference in which one will get antenatal steroid. Even though the evidence for antenatal steroid before 26 weeks, it is not that strong. A lot of it is a more observational study than actually randomized controlled trial. But there's a difference. So there already disadvantage of less antenatal steroid. The same thing when we talk about antibiotic, different mag sulfate, different between the two groups, and even a C-section. So you will not do a C-section at 22, you will do it at 23 weeks, which is very interesting. So if you look at it, they were actively treated around 36% actively treated, where you got majority of 23-weeker are actively managed, at birth. So what is active management? So when they defined it really very clear in the study, so intubation, surfactant therapy, respiratory support, even chest compression and epinephrine, despite the data shows babies born below 25 weeks, when we do chest compression and epinephrine, the prognosis is really poor in these babies. So these are really aggressively, been managed. Now, if you look at the outcome, I compare the two because I'm trying to make a case to say there's no difference between the two. So if you look at the study, when they looked at survival more than 12 hours, they're around 30% almost comparing to 23-weeker, which is higher. The interesting thing, even 22-weekers, if they survive more than 12 hours, the survival after that is really a lot high. It's very high comparing to overall 22-weekers. The same thing survival to discharge at 1 year. You can see there's a difference between them. Discharge home and remain in hospital, there's a difference between the two. But this is the one not been actively treated. But if you go to the next one, which says actively treated at birth, then you can actually see there is really no difference between the two. There's absolutely no difference. If you look for survival, discharge to home, remain in hospital at 1 year, there is no difference if the 22-weekers are actively managed. If you look again at, I looked at other variables, looking at IVH, and you can see that there's no difference between the two groups. Postventricular dilatation, cystic BVL, looking actually about BPD, and you can look at between the two groups. Majority of babies at 22-weekers, as we know, they are still ventilated at 36 corrected gestation. So there's really the majority they are, and 65% of them actually have invasive ventilation. So that's sometimes when we see a 22-weeker still ventilated at 36 weeks, because that is reality. That's how long it takes them. It takes a long time them on the ventilator. ROP, there's no difference between NIC, surgery for NIC, and even if you look at it, the slight difference between length of stay between the two. So this is, again, actively managed 22-weeker. I'm just going to show you some of the data from our Abu Dhabi. So there's a big study that my colleague Vivian Ofik was here from Corniche. They actually went ahead and looked retrospectively at 22-weekers, 22 plus 0 to 22 plus 6, just to see what happened to these babies over the years. So they had around 67 live births between almost 9.5 to 10 years, and out of that 134 born at 22 weeks with average weight at birth 486. So this is now, it just shows overall. So there were 134 ladies came in at 22 weeks plus, and out of that 77 were live birth, 37 stillbirth, and 20 were excluded because some of them already came in with IUFD. They were not in labor. If they were in labor, they were included, but they came in already not in labor. So out of 77 live birth, 49 were offered stabilization. Out of that, 20 were admitted to NICU because others did not really respond. And after the 20, 4 survived to discharge. So you can see, that's the reality of when we're talking about 22-weeker. Okay, so the trend, when she looked over the 10 years, there is definitely increasing trend of actively managing these babies in the last, say, 5 years compared to previously in the labor ward. So there's emphasis on assessment in the labor ward in these babies, which actually led to reduction of admission of 22-weeker to NICU. which is the right way, because you have the chance to speak to the parents, everything else, and that's the difference between the two. Out of the 4 survival, all had post-ventricular dilatation, 1 required VP shunt, have seizure disorder, CP, and developmental delay, 2 discharged home on oxygen, and 1 had and also discharged to long-term facility, and 1 had ROP with retinal detachment. So again, the data are just small, the numbers are small. If you look at it, the number of babies born at 22 weeks overall, it's minute. It's actually minute. So this is just our SSMC been actually, as I said, 3 years now. So we just said, let's have a look, because we've been having ladies come in at 22 weeks. So we had 6, even in a larger unit, so you got a 5,000 deliveries, you're probably going to have 2 22-weeker who's going to come to your unit. That's how many. So it's not a lot of them will be admitted to the unit. And out of that, actually, out of the 6, we had 3 survival, and 1 of them I put neurodevelopmental. That one is still on the unit, and the reason for that, because that baby required actually an Umaya reservoir. So really, what I'm trying to actually do, I'm not advocating that we should be resuscitated in 22 weeks, but I'm really thinking that you really need to make an assessment at 22 weeks like you do for 23 weekers. There is improved survival if you are actively manage these babies. Actively managing, including the obstetric team, giving the mothers the option or the family. Neurodevelopmental disability severe is 1 in 3 in these babies. There's no difference between that and the 23-weeker, which is 1 in 4. And really no published local data to support, that 1 in 3 disability or 1 in 3 survival, 3 out of 10 survival. We do not have that data currently. The only data currently from the Corniche group did not show that. But we still have to kind of discuss with families. So if these babies do resuscitate, you really need an experienced obstetric team and an ICU. And some of the time, as I said, there's nothing we can do because it can happen in another smaller unit out of hours. And you need the most senior person, because this is the discussion regarding what you're going to do next. You need the most senior people to be in the delivery room. Discuss with the parents about what the international data, but the most they're interested is, what is your data? What does it mean because the baby is going to be born here, it's not going to be born somewhere else? So you need to discuss that with them, whatever data do you have. You need to take consideration, parents' wishes. Parents' wishes are really important when it comes to this. Some of these parents who've been trying for 10 years to get pregnant, and then you need to, and that's the only manage to get to 22 after 6, 7 trials. You need to discuss with them and give them the data, and also, support them whatever decision they will make. I think it's very important. We all come UAE as a consultant, all of us, and the medical team and allied health. We come from diverse culture. We different religion, different culture. We know what does actually mean where we were trained, what should you do, and what is the ethical aspect. But it's important you are in a UAE, you have to really abide by the law, which is very clear. We cannot withdraw things. When we start a treatment, you cannot withdraw. We allow natural death. Okay. Social, cultural aspect, you need to take that into consideration. I think, can you just run that video if you don't mind? So this is the twins that I showed you earlier. Now, don't have the sound here. I mean, they are there around 15 weeks corrected. And they're going to be 2 in June this year. Now, I don't have the sound, but actually, the parents now call me and they complain about, they are constipated. They don't come and tell me they have problem with breathing. The only thing actually the boy who had 1 treatment of ROP. They went home without oxygen, They didn't have any IVH, did really fairly well, but they didn't stay in the unit for 5 months. 4 months, one of them another 5. So it's a long length of stay, but actually this is a rare occasion. I was still not changing the way I will do it to say, oh, that one survived. I think when we have 20, 30 babies over the next 10 years, 20 years, I think, well, next 10 years, probably we're going to get back to exactly what the international data will show. So it's important, really, anecdotal, having one survival should not change the way you do things. But I think you just need to collect the data. We're having a larger study, which is actually a prospective study, which my colleague Mustafa from Tawam is leading on it. We're actually looking almost from 2011 data up to almost 2021, 22, looking at really limited viability. So hope these data will give us a little bit more information so we can actually share it with the family when we actually have a situation like this. It is never easy. When you get, each one is individual, like my colleagues earlier talked about the snowflake and each one is different, you have to really not say, oh, it's 22 weeks, there's nothing we can do. You really need to address it by having the consultation with the parents, having a chat with your team, and then make an assessment at that time. Thank you very much.
Thank you, Dr. Faisal, for that excellent talk. I invite Dr. Natalie and Dr. Heidi to the stage as well. Please. So, Dr. Junaid is going to start the questions. The mic is there. I request anyone who has a question to please move up in advance. You may have to queue up if there are many questions, so please go one by one.
So, first of all, thank you very much. Very interesting and it really thoughtful talks. The human behavior, what to do at the extreme of this thing, and stabilizing this thing is really. So my question actually to three people, Dr. Faisal, Dr. Natalie, and Dr. Heidi. The extreme of ages, okay? If you start resuscitating, okay, forget about a minute about the parent wishes. Parents say, doctor, whatever you want, whatever you think better for my baby. And this is the 22-weeker plus 5 days. But the weight a little bit more is like 500 grams, and you start resuscitation. To me, we should follow until the NRP, whatever they said, that intubation, or do everything. Not to stop in the middle, because I found one policy here, just drive that, oh, you just give the positive pressure ventilation, increase the thing, and if the baby is not responding, you stop it. To me, it's a very difficult to swallow it, because how you expect a 22-weeker to respond to your PPV as compared to a bigger baby, which you are intubating right away? So my question to all three of you, it is a human factor, is a psychology, or it's like a decision making by someone that, okay, we decided we can do up to certain limit and will not do it. Any one of you can comment.
I think you raise a really great question, and I think that one of the themes that Dr. Natalie and I were both talking about is there's so much variation in practice, and I think that it's a tough thing when parents tell you do whatever you think, because everyone thinks a little bit differently with that. And so I think it really raises the importance of having standardized guidelines that we all follow, because I think otherwise we introduce our own beliefs, our own wishes, and those vary by every team member there. You might think, as Dr. Natalie talked about before, you might think that everyone's on the same page, but myself as a leader, I might be thinking, we'll follow the NRP guidelines, we'll go to 20 minutes, and if there's no response at that point, we'll stop. But that might be very different for the bedside nurse who's, why are we doing this at all, for the other providers in the room. So I think that we need to have standard guidelines that eliminate a lot of that variation in terms of our own beliefs and what we bring to the table. we can't practice in this vacuum where we pretend like we don't have our own beliefs. I think a lot of times we ignore them and then we pretend we aren't paying attention to them, and then we introduce our own bias. So I think that having a standard guideline and really making sure that everyone on the team is on that same page. We have pre-resuscitation huddles where we talk, does anyone have questions? And I think in these cases where it's emotional for the parents, it's emotional for us, I think it's incredibly important to acknowledge that in the room and say, this is the plan, we will go to 20 minutes, we'll ask at that point. And I think really having that pre-resuscitation huddle can help with some of that variability as well.
Yeah. Yeah, I think really important that individualized thing. I may do something actually this time, may do it differently because there was something else different made a difference. I think, thank God, majority of us have not been in a situation when you have a 22 or a 23 week, or if your family or somebody else is going through it. The parents will say to you before delivery, or doctor, do what you think is right. But when that baby is born alive and is moving and is breathing, things changes, believe me, it does change. And that mother who's been waiting for this, and she will say, doctor, do everything, please. Do absolutely everything. I think you're right when you say that offering that resuscitation, take into account the parents' wishes and all the other circumstances. When I say sometime, when you got a golden child, a golden delivery that she's been waiting for 15 years, and then she always lost the baby early, the fetus, and now it's the first time she got to 22, and that's her last chance, she feels. How are we to decide what is the best way to do it? And this is why I find when you talk of extreme prematurity, it is really a collective decision, and the parents should be in the heart. We tell them what we know, and even what we know is very limited, actually, and it's not evidence. We have, because the variation is so difficult. I mean, if you look at Japan or other areas, they may have a different outcome. They do it differently. So I think you should not have it, I may do it different today, yesterday's, I do something different, say I will do it a week later or earlier. It's different.
Dr. Fauzi?
My question to Heidi, see significant results there. But do you think because when you put the team under more stress by videoing them, do you think that made any difference to the results? And have you discussed that? And after discussion with the team, did they mention that the stress added by video had changed the results? And the second question, and when you saw these results, significant results, and have you done anything to change these kind of outcomes? And would that changes made a difference in the outcomes, like the short or long-term outcomes, like death or disabilities or something like that?
Two very, very good questions. To your first question, so delivery rooms in general are stressful environments. And yes, having it video recorded, absolutely, I think people initially can feel a little bit of increased stress in that. We've now had our video reporting program, I believe, since 2014, 2015. I was still in residency at that point, so I wasn't there when it initially started. There were growing pains at the beginning. There was a lot of work done around psychological safety. We made sure that these videos, they're not used in a judgmental or punitive manner, and there's limited access as to who can access them. We do use them for video reviews with sort of the entire unit, but that's only after talking specifically with all of the providers and getting their assent, not necessarily permission, but assent to use them. I'm sure that there is some stress that's added to that, but we've had it long enough that it's just the standard of care of what we do. And in all honesty, I think it should be the standard of care everywhere, because we need a way of knowing exactly what we're doing there. I think it's something that people need to work through. You have to be really careful with it, and I think you really have to work to get buy-in from everyone. And we've done a pretty good job with that. I think your second question had to do with, have we made any changes that actually show any sort of long-term or even short-term differences? Most of my studies to date have been relatively small, and that's part of the reason I'm trying to expand them to bigger, to be able to see some of those differences. One of the things that one of my colleagues did is we actually have specific places that people stand around the bedside, literally footprints on the ground to map out where people are. And we actually saw that fewer people were touching the patient at the same time. And so we were able to get our leads on faster. We were able to see sort of what the heart rate was faster. And in one of our studies with that, we were actually able to decrease the number of what we call resuscitative intubations. So we were not intubating babies for heart rates under 100 because we weren't messing with the baby. We were allowed to just do PPV. And the biggest change around that came with the actual placement of those spots around there. So it's a small study. I think that it is a hard thing to necessarily prove. We've had some benefits with it, but we're hoping with the delivery room of the future and some of my international collaboratives, we're going to be able to have bigger studies to be able to see some of that. But great question.
Thank you. I mean, just a comment on both Dr. Natalie and Dr. Hades' topics. I mean, obviously, there is a lot of unexpected aspects to resuscitation, isn't it? I mean, we cannot plan all the time, and even in a well-oiled machinery like you have, things can change suddenly and you can't predict. So that unpredictability brings in a lot of stress. And I have one question for Dr. Natalie before I hand to Dr. Mogi's question. So, I mean, your presentation was fascinating, as I mentioned earlier, and obviously you have the opportunity to see so many rare cases, which most of us wouldn't see as much. So how do you share the information apart from publications, and do these guidelines that you make reach the general American Academy, for example?
Yeah, no, that's a great question. Thanks so much. So that is our plan, that we will, like just like Jennifer Dawson did with the oxygen saturation curves, we do want to create those curves and distribute them. And then based on what we find in the delivery room, we really would love to impact the NRP guidelines and really impact what happens not only in our center, but to prove it there with high volume, but then to distribute it widely throughout North America and the world, if we find things. Because we do have an incredible volume, and that's what we say in our center. We're very fortunate to see a lot of babies with anomalies in one way, but with great volume comes great responsibility. Because some centers, it may take 20 years to see the same number of babies with TGA, and we see 40 to 50 a year. So we need to work with that and come up with those guidelines. And it's really hard as a clinician to do that. We work on guidelines and, just everything takes so long because you're in clinical care. But this internal accelerator grant that we got, it really has just changed our world. So the hospital knew that what we were doing was important, and they've put funding into it. So we have extra help. So it's not just like the clinical people, doing our work. We have a team that puts the numbers together, pulls the data for us. So we're just really, it's quite incredible. So our plan is to share this, and if we are able to figure out how to best display the digital content, we're even hoping that we can make that available to all hospitals. Yes. But it might be that you would replace, your phone number for the blood bank with our phone number for the blood bank, but it could standardize, because really the way of the world is not to have a textbook or to have an NRP book or even laminated cards in your pocket, really, right? It's to have a digital coach with you, to have things that are very easy to access.
The visual aspect of it.
Quickly.
The images.
Absolutely.
Yeah.
So that's our plan.
Thank you. Just the final question, Dr. Mogis, and just to conclude, after this question we will finish, but we'll have just a 10-minute break, and hopefully we will start the next session at 11. So kindly stick to the time. Yes, please.
My question is to Dr. Natalie. It was a very exciting talk, and first part already you answered, Dr. Siridhar asked. My second question is that are you targeting certain groups of patients to determine the outcome, like for example, congenital diaphragmatic hernias, as you earlier mentioned that you have made the nomograms for the congenital heart diseases, because congenital anomalies are too many. So what is your real aim Because CDH is the one entity which we all as an neonatologist come across. And did you come with some plan or some recommendations for some particular type of resuscitation for these babies? Because I have seen 2 slides of both of your speakers that you have sensor medics at the delivery room. And that was exciting to see for me also, and how to transfer these babies if you put them on sensor medics and delivery room, how to transfer to an ICU as well. This is my question.
Yeah, so in terms of with the diaphragmatic hernia babies, so we are planning to make recommendations for that. So, because we know they're different, liver up, liver down, depending on their O to E prenatally. There are a lot of things that we know about them before delivery. But again, like I always tell families when I do the prenatal counseling, we have to meet the baby. These are the numbers, this is what we worry about, this is how we're going to start. And we meet as a team, so we meet weekly to discuss our plans for the CDH deliveries. And so if we know that they're liver up or liver down, is there an eventration, a sac, how big is the contralateral lung, is the left ventricle small? We come up with a plan as a group as how we're going to approach that resuscitation. And so what we've done, we've got our critical knowledge screens with that content, and part of the digital coach work is to simplify it a bit. So, we don't need all that information on there if it's a baby that's liver down. We'll just have the liver up work. But we are trying to come up with guidelines and an approach for that, but also based on our previous experience. So we had a number of years where liver downs, when we put them on conventional ventilator settings, they were very hypercarbic and had a severe respiratory acidosis. When we started using the Sensimatics, the high frequency, we've essentially gone away from that. So they still have elevated carbon dioxide levels, but not to the same degree, and their pH is greater than 7071. So we feel like that's helping their transition. So while we're looking at their respiratory mechanics, looking at blood gases, we're going to report all of these things separately and as a group to come up with these recommendations. So it's going to be evidence-based, if that makes sense. And then, did I answer your question?
Yeah, that's fine.
And then, could you repeat your first question for
The
me?
question is that, are you targeting certain group of congenital abnormalities? Because a lot of congenital abnormalities are there, but because you are looking for the transition of the lot, as you mentioned, with the
Right.
congenital abnormalities, but are you targeting certain group of the patients, like CDH or congenital heart diseases only, or omphalocele, or etc.? So what is your basically main aim?
Just a brief answer, please, because we're running out of
Yeah,
time.
we really do want to look to see if they transition in a similar way. There's going to be a lot of cyanotic heart disease that we can lump together depending on the right and left ventricle, but we're going to see, because we assume that babies like with spina bifida have the same oxygen saturation curve, but we don't know. So that's what we're looking for now.
Thank you. Just a quick question to Ayman. You had a very nice presentation, very important topic as well, and being the Nurses' Day as well, I mean, it's a very important topic for nurses as well as anyone who's involved with transport. So is there any program in the UAE for the stable course?
I'm not aware of, not yet.
You're
but
planning to
something-
organize
that's
one
something,
with
yeah, I'm
Dr.
kind of, yeah.
You're arranging it. Good. So I think, Dr. Anwar, we have to finish the session because we have 10 minutes for the next session. If you want a quick comment or question, please go ahead.
One question only for the transport.
Very brief, yeah.
Yeah. My question is timing of the transport of extreme premature baby. As you know that if you transport very early, there is a high risk of interventricular hemorrhage and things like that. So would you ask them to, the referring hospital to stabilize more the surfactant use and all these, so that at least this period is gone, or you are going to take the risk to transfer it immediately after the delivery?
It's
Very brief
important.
answer, please, just 1 minute.
Yes. So I think is the dynamic here in the UAE a little bit different from the United States. In the United States, usually we would like to send our team if there is no impossible to transfer the mother and stabilize the baby, so we can shortening the time, expertise people. But here, unfortunately, every hospital is responding to transfer their baby. So it's depending on the hospital capacity. So that means whenever they have the capacity, if they're pediatrician, I rather stabilize the baby as much as he can and transfer the baby. Don't waste his time, try to resuscitate and give something that he's not familiar with. Make sense? So it's variation of the practice here. Still, we are working on it.
Thank you. Thank you to all the speakers and thank you for the organizers.